Welcome to Quality Time, a Houston Methodist leading medicine podcast. I'm your host, Dr. Schaal, a clinician scientist and a retina specialist, and I serve as the Chief Physician Executive of Houston Methodist, located in the world-renowned Texas Medical Center. I passionately believe that quality is the heart of healthcare, and a commitment to quality is essential for every healthcare system. Join us each month as we discuss the latest advancement in quality in healthcare with clinicians, researchers, physicians, industry experts, and thought leaders who are as passionate as I am. It is my absolute honor to welcome today's guest, Dr. Robert Grossman. Dr. Grossman is Chief Executive Officer of NYU Langone Health and Dean of NYU Grossman School of Medicine, and he is nationally recognized as a top healthcare executive. Under his visionary leadership, NYU Langone has been ranked number 1 in quality care in the U.S. for the last 3 years in a row by Vizient. He has transformed NYU Langone into one of the best integrated academic health systems in the United States. Welcome, Dr. Grossman.
Thank you. Nice to be here.
Tell me a little bit about yourself and about your background. How did you become what you are today?
Okay. I trained in neuroradiology, and then in 2007, I became the Dean and CEO of NYU Medical Center at the time, which then became NYU Health System.
So from neuroradiology, how do you get to be a CEO? How does that happen?
Probably a lot of luck. Ken Langone, who was the chairman of the board, saw something that interested him in me and thought that I would make a good CEO.
Fantastic. And, since you became CEO and Dean in 2007, you've really completely transformed the medical center and you have a unique approach to medicine and quality management. Can you tell us a little bit about that?
Sure. So the keys to our success, I think, revolve around, number one, integrating the school and the hospital. So there are very few academic centers, as far as I know, that are totally integrated. And what you referred to, my title, Dean and CEO, but every one of the executives has a title, both in a hospital title and a school title. So it reduces the administration significantly and administrative costs. It creates a lot more efficiency. There are a lot less interfaces to navigate. So combining the school and the hospital and aligning them was very significant. And that is very difficult to do in academic medical centers, as you would understand. The second thing is our model. We changed our business model from a hospital model to an ambulatory model.
What does that mean?
Okay, that means that instead of having a lot of hospitals, we have a lot of ambulatory centers. So we have over 300 ambulatory centers in the New York metropolitan area.
Wow.
And in Florida. And about 62% of our revenue comes from ambulatory. And that was a very unusual business decision in 2007.
It is, because it's less profitable, right? Ambulatory clinics are less profitable than hospitals.
It's actually more profitable because your expenses are lower.
Expenses are lower, but then the reimbursement is different and lower, right? Depending upon the business.
Some of it, but yeah, sure. But it also feeds into the quaternary hospital business. So your expenses are lower. You actually, Article 28 Article 28 facilities or hospital-based facilities, uh, but you are much more efficient. So that was the second thing. The third thing was we were going to be very data driven. So it was all about data. And I always say metrics are happy ways of doing things.
So, what kind of metrics did you insert?
So every kind of metric in all three missions. So we have over 800 metrics that are contemporaneous that are on a dashboard that everybody sees. So we created all this transparency, which behaviorally affected uh, quality. So if everybody sees everybody's infection rate,
Uh-huh.
uh, everybody sees their readmission rates, their length of stay, et cetera, it has a profound effect.
Yes. So you were number one in the United States 3 years in a row. And not only that, I looked at the data of Vizient, actually way ahead of everybody
Way
else.
ahead of everybody.
So,
And actually, what it doesn't show is something else. Our cost per discharge is the lowest, or one among the lowest in the United States. So, and our EBITDA is among the highest in the United States.
so tell us a little bit. Let's say, okay, you're so far ahead of everybody else, and this transformation happened, since 2007, which was, not too long ago. How can the rest of healthcare systems do that? You told us three things. The first one, you said medical schools and hospitals, are better integrated than not integrated. Is that a movement that will happen? What is your take on that?
Well, I think it's very difficult to do. It's easy to say, it's difficult to do because politically it takes a lot of courage to do it, because you eliminate positions, you eliminate board structures, because traditionally hospitals and schools have separate boards. They don't have overlapping boards. So that's very difficult to do.
Yeah, so the majority of medical schools, at least in this country, United States, are separate completely from healthcare systems. There's very few examples, and then I don't know of an example that actually, it was integrated. Is there another healthcare system like that?
Well, some are integrated, they look integrated, but they still have a hospital president. We don't have a hospital president.
And then the second thing, moving from hospital to ambulatory, I think is a national movement, but people are worried that still, maybe the largest margins are with the most complicated cases, such as transplant, neurosurgery, big procedures that cannot be done ambulatory.
Sure, but a lot of surgery. uh, So actually, I think I understood pretty early that medicine was moving to minimally invasive ambulatory, and that um, creates, if you do it correctly, then your hospitals, the length of stay decreases, right? Because um, you have more beds for the sickest patients, is what I'm saying,
Uh-huh.
right?
So trying to keep people outside of the hospital if possible.
Outside of the hospital, only the people who need to be in the hospital. So therefore, you can effectively have better beds, if you
Mm-hmm.
know what I mean.
Yes. Okay. So beds that are saved really for the people that really need them the most, and everybody else can.
Correct. And if you look at our metrics, we also have the shortest length of stay in the United States.
Yeah, that's a challenge for many. I know it's a challenge for us here at Houston Methodist to keep length of stay short. Is your tip build more clinics? Is that how we shorten the length of stay?
No, well, I think in order to get the shortest length of stay, you have to make the diagnosis, have minimal complications, and get the patients, be very efficient in the way you deliver healthcare within the hospital, meaning uh, patients shouldn't wait for radiology procedures, shouldn't wait for blood tests, things like that. That it's about efficiency and about quality, and that all concatenates in length of stay.
You said you had 800 metrics. And then
Yes.
these are transparent and accessible, and they're updated in real time. People, if I
Real time, real time. Yeah.
and so how do you educate people what to use, what data to use, how to improve?
Everybody, there's an accountability across the system. At the highest level, every 6 months, we do something called a snapshot, where we bring the chair and the administrator into a session where all the senior executives are there. We have all the data. We give them 5 minutes to talk about what they've done in the 6 months. We talk, if they have issues right there, you have the people in the room who could deal with the issues. And then we talk about the metrics and who isn't performing and what the solution is. So that happens every 6 months. So there's a tremendous amount of accountability in the methodology. Plus, the snapshot also makes the chair confront the material.
And so the chair is responsible for the hospital side. Is the chair responsible also for all ambulatory clinics?
Yeah, so we have local site people, but ultimately it all rolls up to the chair.
Interesting. The reason that I find it interesting is that a lot of times department chairs are selected because they are, excellent clinicians or extraordinary scientists, and not necessarily, because they're good leaders or managers. Did you select different kind of chairs, or did you train them? What did you do?
Ultimately, it's a pretty centralized system. But we work with them continuously. And we also work with our basic science chairs too. We're very metrically driven, as I said. We also have the highest NIH dollars per square foot.
Because of that metric system and because of that high
Exactly.
accountability.
So we're metricized in all three missions, actually. We care deeply about performance.
So the chair is responsible for all three missions. Let's say the chair of surgery.
The chair, well, the chair is responsible. If they have research in surgery, they are responsible. Now they deal then with the vice chair for research, vice dean for research. So there are these discussions, but there's a lot. We don't have silos here, which is also because we're so integrated.
So
Everybody, all the senior management here is on one floor.
On one floor.
Yeah, very. So we have very small senior management team, and everybody. You can walk to somebody's office and say, "What the heck is going on here?"
So interesting. So, every 6 months, every chair, happens for every
chair, an institute director.
An institute director. They come to that floor where all the management.
They come to this room where all the senior management is there. They present what they're doing. We look for alignment, and we discuss all the issues in a very unvarnished fashion.
Wow. Okay. Well, I would like to be a fly on the wall in one of these meetings for sure. I did look at the Vizient results, and I noticed that NYU is so far, not only first place, but also so far ahead. The question is, even though we are measuring the same metrics and Vizient is comparing, right, healthcare systems one to another, and it's like benchmarking, it is really, a different micro environment that we are, in. You're in New York City, we're in Houston, other healthcare systems in different parts of the country. There is local politics, there's also local culture. Who seeks healthcare? What's the access to healthcare, and so on and so forth. Are we comparing apples to apples?
Yeah, I think the people who say what you just said are making excuses.
Interesting.
You have to. A lot of people, when they don't like the outcomes, criticize the method.
Well, let me just say, for all our listeners, just to emphasize, Houston Methodist is a top 5 in Vizient. Our academic hospital is top 5, and all our system hospitals are really top 5. So, we are performing well, but there's always this, okay, well, we're doing everything we can to improve. And it seems like still, top performers are top performers, and then middle performers are middle performers, and bottom performers are bottom performers. And the question is, why? Does it relate to payer mix? Does it relate to patterns? And you don't believe that?
Well, that's the same dodge that in New York hospitals say when they underperform. We have a lot of safety net hospitals. They're associated with academic systems. We have a population that's highly diverse, that's very poor, and that's why our hospitals don't do well. But we have we have one hospital ID for our hospital. So everything aggregates, consolidates to us, right? So we have a hospital in Brooklyn that's an underserved hospital. And that was a failing hospital before we took it over. And they have the same metrics as we do. And so I think it's about leadership. It's about accountability. It's about making sure that everybody is aligned with what you want to do. One of the other things we said was we want to own the quality and safety space. And those things, the mission and driving that mission and driving the metrics is about leadership. So you could make all the excuses in the world why your hospitals or this hospital aren't like ours. But at the end of the day, what we said was, okay, we're the only system that has 5s in CMS throughout our hospitals, right?
No, we also have all 5s.
Okay.
I have to say.
All A's,
All A's.
all A's in leapfrog.
Yes.
And number one in quality, the lowest mortality in the United States, the lowest readmission rate, the lowest length of stay. So there's something about that methodology that regardless of where you are, if you're part of an underserved hospital, you're in Manhattan in an academic medical center, you're out in Long Island, that makes a difference.
Fantastic. So you are actually saying, there are really 3 things that you think that contribute to that. That's the school and hospital aligned together with one leadership, the hospital getting to less hospital-based and more ambulatory-based, and keeping people actually outside the hospital if they don't need to be there, and taking care of them in the ambulatory setting. And then I think maybe the most impressive or the strongest thing is really data-driven organization and holding people accountable by snapshot meetings and really, as you said, dashboarding everybody and making sure that everybody's on the same page and making progress.
But I would say, so it's really also about aligning the quality space vision with execution of that vision, and being very focused on that. That you have to know precisely what you want to do and what you don't want to do, right? You can't be everything to everybody.
Correct. What is that you don't want to do?
So we don't have to be the biggest hospital system. We want to be the best. So we're not an insurance company. And the other thing is, we're focused in the New York metropolitan, in the areas that we're in. And then the other thing is, when we do a merger of an institution, it's our culture. We only have one culture. Our culture is really an aspirational culture. And where people, and I'd say it's a meritocracy, but also I always say it's an adhocracy.
Oh.
So if you have a good idea, we buy into it, and we're investors. And traditionally in institutions, there are a lot of barriers.
Yeah, so you basically you're alluding to your innovative mindset, right? Accepting
And taking risk. We're okay at taking risk. It isn't. We're not a organization that relishes the status quo. Number one, we created a 3-year medical school. We spent 12 years raising um, enough money to have two tuition-free medical schools, debt-free medical schools. Uh, in terms of risk on the clinical side, we were the first implementers of enterprise Epic in New York State. So we were the first to do New York State billing. Some people put it in on the inpatient side, but we did the complete enterprise-wide rollout. And that was a very big deal.
yes.
Today everybody says, "Oh yeah, the
No, it
electronic
was a
health
very
record."
big deal. It was a very
Very
big
big.
deal.
And then we bet the ranch on the ambulatory network in 2007, 2008.
So why not more people are not adopting this ambulatory model?
Because it's
Specifically here.
hard to do. It's hard to do. All these things, they sound easy, like an integrated academic medical center. You would think it would be obvious, but it's very difficult to really do it for people to actually give up something, right? How many people, as head of school operations, want to give up that title? How many boards want to dissolve? Very difficult. How many hospitals want to say, I'm not going to invest anymore in the hospital. I'm going to invest in the ambulatory network. It's not so easy and it's taken a long time. And that's the other thing I would say. If you think about the average tenure of a dean, uh, all all in is 4.5
I
years.
know.
If you take out interim deans, it's about 6 years. You can't do anything in 6 years. It took us 12 years to raise the money for tuition fee. You look at CEOs, same thing. And a lot of them
Why
are
is the
risk
tenure
averse.
so short, though? What do you think?
I think that some of it has to do with the fact that the selection process chooses a lot of times the wrong person. What I would say uh, is, again, in medicine, correctly, doctors are risk averse. That's good.
Right.
As a retina surgeon, the last thing you want to do is a new procedure on somebody and have it bomb.
Absolutely. It's funny because, I always tell my students over here that every time I go to the American Academy of Ophthalmology, there is a debate session where somebody introduces new techniques or new devices and kind of pitches. And then on the other side, another person stands and says, no, we should continue and be conservative. And then the audience votes, and inevitably everybody votes to keep things the way they are.
Of course, right. So you're selecting conservative people and
Yes.
conservative, and that's part of the profession. On the other hand, in the job of CEO, if you're conservative, you're going to always vote for the status quo.
So you need some courage and you need some risk taking. Tell me a little bit about the tension, the traditional tension, and maybe it's less tension in your system between the academics, the clinical, the research, the teaching. There's always seems to be some kind of tension. At least, in our system, we are paying physicians mostly for clinical productivity. And, there's some kind of, okay, well, I want to just do clinic and I don't want to teach because you can't pay me enough to teach. Is that eliminated in your system, or how do you handle that?
Well, that's one of the virtues of our system, where we don't have to. The CEO doesn't have to negotiate with the dean. The dean doesn't have to negotiate with the CEO for money. And so we don't have something called flow of funds.
Aha. So it's everything is one source.
Everything is one source, so we just allocate it.
Aha, fantastic. And is this, I mean, how much is allocated for academics? I mean, percentage. I mean,
Yeah, so I mean, what about there's about $800 million that goes to the school a year on the clinical and research side.
yes. Okay. And this is your decision to make, and you don't have to negotiate with anybody. That's
Yeah,
pretty
it
powerful.
makes it easy, right?
It makes it easier if there's one person, but it's interesting. Yeah. So you think that this model will remain? I know you're going to retire next 2 years sometime, and you think
Right.
that this legacy is going to stay after you're gone?
I hope so. I believe it's a very good model. It creates, as I said, a lot of efficiency, a lot of it diminishes barriers. It's a model that people have to get used to.
If you had to imagine NYU Langone in 10 years from now, on the trajectory that you set it to be, how would it be different than it is today?
Yeah, I think hopefully it'll be better. And meaning it'll have organic growth, and it's growing by leaps and bounds, but we have to make sure we can manage the growth. Uh, I think it will continue to represent the highest quality in healthcare in the United States, and it'll attract the best physicians and researchers and students. And if it does that, it will fulfill its mission, frankly. But it's one every day. You have to be out there and constantly shaking the trees, right?
Absolutely. So it's a really, you have to be present through this entire. So whoever replaces you and get into your big shoes will have to really pay attention to all of this.
The details. So I think as a leader, you have to have the vision, but you also have to be into the weeds, because it doesn't, if you just have the vision, it doesn't work. You have to be, if you just are a micromanager, that doesn't work. You have to have a combination of the two, and you have to be able to execute. So a lot of people have good ideas and can do everything, but they can't execute what needs to be done. And you see that a lot.
Yeah. Do you think, you're a physician, you're a physician CEO, you think more physicians should be seeking that track, or, let physicians be physicians and let healthcare systems be managed by really business people?
Yeah, I think physicians should manage health systems. I think so. In the United States, I think only 5% of CEOs are physicians, which is not good. And I think physician systems are different. Yeah, so they're much more attuned to quality and safety and not all the other extraneous garbage that yeah, that goes along with a business person. The business people are wonderful, but physicians intrinsically, most of them understand quality and safety. We did here, and this was very important to me. And let me preface this. If you look at businesses, they invest an enormous amount in leadership training. Medicine, I've said, has always been the caboose. The military invested in leadership, businesses invested in leadership, academics and academic medicine, you know, have spent very little time in investing in leadership, and the results have not been good. And so here we created the NYU Langone Academy for Leadership, and we have people at all different levels who we select who go into the Leadership Academy, and we've had thousands of people at all different levels, and it makes a huge difference across the campus. And I think the Leadership Academy has also enabled us to drive quality and safety.
one question that I love to ask all my guests here is, what does quality mean to you?
Yeah, so I think quality has many dimensions, on how the patient perceives quality, and that is how efficient the service is, how excellent it is, their perception. Then it's the professional understanding of quality, where you're really looking at metrics and you're benchmarking to a standard that is very important.
Excellent. Well, thank you so much, Dr. Grossman. This was for me, it was really an honor to speak with you. And thank you for what you're doing for patients and actually, setting kind of a northern star for everybody else to follow. Thank you so much.
Okay, my pleasure. Nice to meet you.
Nice to meet you. And thank you for listening. Quality Time is part of Houston Methodist Leading Medicine series of physician-led podcasts. So that you never miss an episode, subscribe to Quality Time. New episodes will download to your podcast device. If you enjoyed our conversation today, please consider rating this episode and sharing it with your colleagues. I appreciate your support. Thank you. And until next time, I am always listening.